Hello, everyone. Hello. Just one second. I'm hearing an echo. Right back. Can you guys hear me? Hello, everyone. Uh, I think I'm hearing an echo. So just one second here. See if I can get myself. All right. Okay. Hi, everyone. Sorry for the technicalities. I actually had this on two computers. So I was hearing myself on the computer uh, on my right hand side and also hearing it here. So I had to get that out of the way. I hope everyone's having a wonderful, wonderful, wonderful Friday. Let me just see. Is everybody hearing me? Okay. Hi. Hi, Abba. How are you doing? Hi, Miss Wanda. How are you? How are you guys? Good evening, Pamela. How are you? How are you? Um, and okay, we have questions right away. Okay. Well, welcome, 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 welcome to Q&A with Dr. Mercy. It's been a while. I know previous weeks we've had some special episodes, and so we've had to kind of not do the show for those weeks. But I am back. So hi. So on this episode, we're going to talk about two topics. The first topic we're going to talk about is just a continuation of our usual COVID, just COVID updates. We're going to talk about that. And then after that, we'll talk about pain medications. I do see some questions. So if you do have some questions, just make sure to put them in the comment section. I know I'm just seeing one particular question. Doesn't have to do with our subject, but I do want to address this. I know Andre West said, if I have a peptic ulcer, what's good for it? I know milk is Maalox good too. So obviously, if you have, how do you know you have peptic ulcer disease? This is a very good topic, Andre, and thank you for pointing this out because a lot of people have indigestion, they have abdominal pain, and pretty much they could have an ulcer. And they don't know, and it has not been diagnosed. The only way you can know if you have an ulcer is if you have an endoscopy, which is where they put a camera down your throat and they look in the lining of your esophagus, they look in the lining of your stomach region, they even look in the upper parts of your intestine. So for indigestion in general, yeah, some people do use milk. Maalox is also good too. But if you have peptic ulcer disease, you want to go a little bit further. And this is where prescription medications are used, okay? So you want to know, okay, what could be causing peptic ulcer disease? Because there's some certain bacterias One in particular, Helicobacter pylori, which we also name H. pylori, which can cause peptic ulcer disease. And so drinking Maalox, drinking milk, or even just the typical antacids like over-the-counter Protonix that we have may not properly heal that ulcer if you do have a bacteria that's causing it. You want to kill the bacteria first. And so there are certain tests that we do to figure out, okay, why do you have the peptic ulcer disease? Is it because of a bacteria? If so, let's get that treated. And if not, is it just simply because you're just producing too much acid? And this is also where diet comes into play. And so in all the nutshell, I mean, for temporary release, you can try milk, you can try Maalox, but for long-term relief and to actually prevent and heal the peptic ulcer, I would suggest just going to the doctor, making sure it's a peptic ulcer first, and then figuring out what it is that's causing it. But great question. That wasn't what I was going to talk about, but I saw it and I wanted to address it since you did ask that question. Okay. All right. And you said you had that done, Andre. So you had the EGD done. Okay. So I hope I was able to answer your question, Andre. Again, I think this will be a good topic to discuss, and maybe I can get a GI specialist on board and they can also, kind of talk more about it. So thank you so much, Andre, for that question. Okay, so now let's talk about COVID updates. The reason why I wanted to bring that up, I know our topic for today is about pain medication and about the myths of pain medication. You're welcome, Andre. The myths of pain medications. And so I wanted to go over 10 myths that I've seen in the hospital when people talk about pain medications and when I'm prescribing it to them in the hospital. There's a little bit of misconceptions, and I wanted to address it, especially given the fact that we have a opioid epidemic, we have a drug overdose epidemic. I wanted to say what is true and what is not. And so how do we prevent addictions, and what do we do, and how do we use pain medications appropriately? I want to talk about that. So we're going to talk about that later on in the show. But before we do, I just wanted to kind of give you a little bit of update of COVID. Since we always talk about COVID, let's kind of talk about what the latest updates are. Well, the latest updates is, if you guys have not seen already, that the CDC has said that everyone, adults mainly, can now get the booster. So those who are above 18 and older can get the booster shot. Now, the booster shot is particularly for those who've already gotten their full dose of vaccinations. So if it's a Pfizer, it's and the Moderna, it's the 2 shots. If it's Johnson & Johnson, it's a 1 shot. And you're 6 months out from that last dose. So they've looked at those who've gotten the booster. I've gotten the booster. I can tell you I've gotten the booster, and they so far have not seen any major adverse effects. The reason why they want people to get the booster now is, especially when we're coming up to the holiday season, we're sharing a space with our family members, maybe close friends. And so they notice that when you get the Pfizer or Moderna shot, after certain months, the immunity that you create from getting the vaccination starts to wane. And so they're thinking around the 6-month period of time from the last shot is when you should get a booster shot, meaning you should get another dose of the vaccine to boost up your immunity so your immunity can produce more antibodies against the COVID vaccine. And they still see, and I still see, that the majority of the people who are in the hospital because they're unvaccinated. But their concern was they were starting to see a little bit of those who did get the vaccination, as they should, start coming in because of COVID. So that's when and not only that, they also were looking at Israel, who, they started the vaccination and they've been doing studies kind of longer than we have. So they're looking at what's going on in Israel, as well as seeing that there's a small minority amount of people who are coming into the hospital with COVID, even though they got the vaccination. So then they started to think, hey, I think it's because of the antibodies for the COVID, even though you appropriately got your 2 doses, are not enough because they start to wane off. And so they specifically, would like those, especially those who are 60 and above, those who have comorbidities, those who are immunosuppressed. They specifically say, they encourage you to get your vaccination. But they say that everyone above 18 should, and if you're 6 months out from your vaccination, should definitely get the booster. So I got the booster. The only side effect I got was the same side effects I got when I got the first and the second dose of Pfizer. And that is, I got the fatigue, got a little bit of headache, and I got the muscle aches. Usually typically lasts 24 to 48 hours and you're good. And so I already knew what to expect on this coming one. I knew if I was going to get the vaccine, it was going to be maybe similar minor reaction. And so I made sure to do it on a Friday so I could chill on Saturday and Sunday. And before you know it, it was over and I was good. So again, I encourage those who feel who feel that they're beyond the 6-month period of their last dose of vaccination to definitely get it. And so I just wanted to just clear that out. And let's see. So now let's talk about what we were going to talk about. And what we're going to talk about today is, like I said, is prescription pain medications. Are they your friend or are they your foe? And like I said, the reason why I am doing this is because I read in a recent article that the US has reached the 100,000 deaths from drug overdose within the last 12 months. And that is about a 29% increase in drug overdose deaths. And so it got me thinking about the use of pain medications and what it is and what it isn't. In that particular article that I read, they said 75% of those who had drug overdose was because of opioids. And so, yeah, it made me decide, okay, let me talk about opioids and what it is and what it isn't for everyone, so that there's some clarity. Because as I try to tell my patients when I'm in the hospital, they tend to not really have an idea of what pain medications can do and what they cannot do for you. So I just wanted to just make things clear. And so that, and if you need pain medications or if you have to be in the hospital, you're well informed. So opioids, whenever we talk about opioids, what are those? Well, they're the family of medications that contain this molecule, or maybe codeine, which is a type of, I want to say, medication or substance. And from the codeine family, there are different medications that have been designed with that particular substance. And one main one that you probably hear about is morphine. But you also have others who take things like Norco or oxycodone or fentanyl is the new one that people take a lot out in the hospital, and they take it as a drug outpatient, as well as they go and they take it as an illicit or street drug. And then you have also some of the other street drugs. You have heroin, which is in the opioid family. So opioid medications obviously are used for, pain and to numb pain out. So that leads me to the first myth. So pain medications in particular can fix the pain. And that's not the case. As we all should know by now, and in case you don't, when you use pain medications, it's not necessarily to fix your pain. What it does, it numbs and it masks the pain so you don't feel it, right? And so the purpose of that is so you're not in distress while you're getting treated for what's happening underneath you. So if it's trauma that's causing you to have the pain, if it's some sort of infection, other types of illnesses, the pain medication just numbs the nerve endings that are surrounding that area of inflammation or that area of insults, and causes you to feel calm. Okay. Some people, and I've heard it in the hospital before, think that if you take pain medications, it fixes it. No, it doesn't. It just numbs it. So it would be something like if you had a fire and you had a fire alarm and the fire alarm goes off, you just knocking off that fire alarm is not going to treat what the fire, right? No, it's not. It's just going to stop the noise, but the fire's still there. The way to really, really treat whatever is ailing you is by adding the water for the fire and dousing the fire and letting the fire go. And that is what will now fix the pain. So just keeping that in mind can make you realize how you should treat pain medication. So I just want to keep that in your mind, okay? Myth number 2. This is what I get all the time in the hospital, and rightfully so, because especially with the pain overdose, you're hearing about opioid overdose, you get scared. And so myth number 2, if you can take one pill, pain pill, and you will get addicted, just one pill. And I get this all the time. People are like, oh, I don't want to get addicted. And I'm just like, sir, but you have pancreatitis, or sir, you have appendicitis. That's painful. Yeah, but I don't want to get addicted. No. Taking pain medications in a short-term basis, usually within a couple of days, the likelihood of you getting addicted is very small. I've read in studies that people get addicted when you start using them in a couple of weeks or more. And even then, I can't even say, each person is different. So I can't even say if you take it for 2 weeks, you'll get addicted. You just need to be mindful when you're taking pain medications. Yes, can it be a medication that can cause addiction? Yes, it can. But you have to be mindful of the risk, benefits, and risk. If you're still in pain, and this is something to be used acutely, as we say in the hospital terms, or something to be used for the now, a short-term thing, it's appropriate for you to use the pain medication if it's going to allow you to do your daily life activities. It's when you start using the pain medication even though you're not in pain, that's when you have those issues of, I'm now addicted. So like I said, when you use pain medications on a short term, it's okay. Just be mindful when you start realizing that the medication you're using is more than just for the pain, because pain medication can make you feel some sort of like euphoria for some people. Myth number 3, the more pain pills you take, the longer and the better they work. So this is another thing that I get in the hospital. Usually for us physicians, especially in the hospital, I can speak for myself, I don't want to start you on in the high dose of pain medications. I don't want to start you on that because I don't know how your body's going to react. And each person is different. So for one person, they may be okay with 2 milligrams of morphine, okay? But for somebody else, it may require 4 milligrams, or it may require more frequent amounts of the morphine, okay? So we tend to start you off on a dose and escalate it to where it's acceptable for your pain and for your body. Some people think that they always need to start with the toppest of the top, and they always talk about the D word. And I won't say it here because anytime I hear someone say, oh, I need that medication and it starts with a D, I'm like, okay, no. What you need to do is you need to allow your body to first figure out what's best for that particular pain. Even if you use the medication that started with the D for your appendicitis that you came in for 2 years ago, doesn't mean that you still need that medication that starts with the D, which is a high potent medication. You could just need a small dose of morphine for that next pain. So stronger dose does not necessarily mean it's better, and it definitely does not necessarily mean it's longer, okay? If anything, when you take a high dose of pain medication, obviously that's how you can get overdoses, okay? When you don't take it as prescribed, when you don't take it under a controlled environment. Or if your doctor does not prescribe it for you and you just take of someone else's prescription. Because let me just say this, let me just say this. when you take high dose pain medications that are not adjusted for your particular body or for the particular situation you're in, you run the risk of having these effects like your breathing stops, you start getting confused, you start getting very sleepy, and it just your body starts to kind of slow down. Okay. So that's why, as physicians, we know signs that can say, oh, wait, you're taking too much pain medication. If lots of the times, I'm not saying all the time, but for majority of the time, a lot of us physicians are very mindful with the medications that we prescribe people, and we start low and adjust as necessary. So that's that on myth number 3. Myth number 4 leads us to myth number 4, since we're talking about reactions. Common reactions that I get from people in the hospital is, oh, I'm allergic to morphine because it causes nausea, it causes me to vomit, it gives me a headache, or sometimes I get confused. Okay, that's not an allergy. I think a lot of people get confused between what an allergy is and what an adverse effect of a medication is. Okay. Now, an allergy is, when you think about allergies, what you're thinking about is, I'm itching. I break out in hives. My throat is closing up. I'm having a very hard time breathing. I'm going into almost an anaphylactic shock. That is true allergies. So, but sometimes people think that whenever they take a medication and they get a reaction, then that's always an allergy. No, that just may be your body's way of reacting to that particular drug. So with things like morphine, for particular, not so much the pills that I noticed, but definitely the IV medications. A lot of people complain of nausea and vomiting. And if we have to give it to you, a lot of times we also make sure that you have something for nausea just in case you need it. So that's something to keep in mind. Also, another thing to keep in mind is, if you put morphine as an allergy and it truly isn't, or you put codeine as an allergy and it truly isn't, and you need a pain medication in the hospital moving forward, it's very hard for your physician to be able to give you a medication that does not contain codeine or an opioid. So always make sure that if you are allergic to codeine or allergic to morphine or allergic to Norco or any of those opioids or any of those medications that contain codeine, always make sure that that's a true allergy before you say I'm allergic, because that can adversely affect you in the future if you're going for surgery and you need a pain medication, or if you have like a acute illness, like I said, appendicitis, and you need pain medication, because you have the one opioid or one codeine containing medication as an allergy. It kind of limits your doctor to giving you, I want to say, up to 80% of the medications that are out there that are in the hospital when it comes to pain medication. So be mindful of that. When you have an allergy, true allergies is if you're itching, if you break out in hives, if you have difficulty breathing after that, or you feel your tongue your tongue is swollen, or you feel like your throat is closing up. That's true allergy. And obviously, if you have a true allergy like that, you don't want to take it again. So just be mindful. Okay, so myth 5, pain medications are the only ways to treat pain. And that is another misconception that people always have, and something that people need to also be aware of. Just because you have pain doesn't mean that we need to give you that opioid, okay? A lot of times for patients, if it's just mild pain, I start with things such as Tylenol, and I start with things such as like ibuprofen. I'm mindful, especially when it comes to ibuprofen, that they don't, and be mindful when it comes to ibuprofen, Aleve, anything aspirin, that you don't take too much of it because it can irritate the lining of your GI tract, and it also can cause kidney issues if you take too much. And the other hand, with Tylenol, too much of Tylenol is also bad as well. Too much of anything is bad in general. So if you take Tylenol too much, it can cause issues with your liver. So I always, as a mild pain, I always give my patients, see if Tylenol, if you have a headache, see if Tylenol can help you, or, and then after that, if it doesn't help, then I go to something a little bit stronger. But not all pain is relieved by opioids or narcotics. For example, nerve pain. People like diabetics, they tend to get long-standing diabetics. They tend to get what they call diabetic neuropathy, where they describe pins and needles in their legs. And so for them, they don't want opioids. They want a nerve numbing medication. And, we prescribe that. People who have this condition called restless leg syndrome, where when they're at night, it's hard for their legs to stay still. They don't really get relief with pain medication. They get relief with certain medications that helps open up the vessels within their legs. So if you come in and with pain, not all the time you'll get an opioid. There are other medications that can help you as well. And then also, especially for those that have chronic pain, like arthritis or back pain, yes, in the brief period of time, you want to get something that will help relieve it. But you keep in mind, there are other things that can also help relieve that same pain as well. Exercise, physical therapy. You'll be surprised how that can help release the tensions of the muscles, and that will ultimately help release the pain. Meditation, prayer. I mean, that's the most important thing. Praying can help relieve your pain. Sometimes exacerbations of pain can be caused because you're not sleeping enough. Okay, you're stressed. Okay, you might be depressed or anxious. That can exacerbate your pain. So there is a connection between the mind and the body. So that's again why, especially for those who have chronic pain, to go beyond just taking pain pills. Look for other ways, non-pharmacological ways. I also read a study, I read it in residency, and it's confirmed that even acupuncture can help ease chronic pain. So going to an acupuncturist and seeing what ways can help you when it comes to chronic pain could be another way to resolve it. So myth 6, you shouldn't take pain pills because it inhibits character building. I've heard this a lot. A lot of people, when you want to give them pain pills, and even close family members, when you talk about, I need something for pain, they're like, no. You shouldn't be taking pain medications. When I had this pain, I withstood that pain and it was gone. I prayed it out, which is good. It's good to pray. You should pray. If you have any ailments, you should pray. I'm not saying you shouldn't. But it is also okay to take the pain medication to numb the pain if it's for short-term basis while you resolve whatever it is that's ailing the pain. What people don't recognize is if you have uncontrolled pain, it can affect your body negatively. I see in the hospital, those who have pain, they're always in a high blood pressure, uncontrolled pain, let me say. They're always in high blood pressure. They have elevated blood pressures. They have elevated heart rates. And that's especially for those who are probably are not able to vocalize they're in pain. That's, for me as a physician, one of the ways that I can see whether or not they're still in pain. Because if I see your blood pressure being high or I see your heart rate being high, I'm like, it could be pain. Let's go ahead and give them a little bit of pain medication and see if that will help. But if you have uncontrolled pain for a long period of time, that having elevated high blood pressure or elevated heart rates can adversely affect your heart. It can inhibit you from sleeping, okay, which will then disrupt your sleep hygiene. It can cause emotional distress if you have uncontrolled pain, okay? And if you had pain within your chest, let's say you fell and you had a rib fracture, which is really painful, but because you want to, you can't take pain medications, you're trying to fight it until it heals. You're going to stop, you're going to, just taking a deep breath will cause the pain, right? And before you know it, you're not taking good deep breaths and you come back into the hospital with a pneumonia. I've seen that happen time and time again. So if you have the pain, it's important to get it controlled. Again, it goes back to a previous myth that I said. Being on pain medications for a short term is okay. It's when you start being on it for long periods of time and even beyond when your pain is gone away, that's when you start thinking about addiction. So even when you're on the pain medication, just be mindful. I only take it when I need it. Myth 7. Pain medication should be taken even when you don't feel like you need it. And we've discussed this before. We're discussing it now. That's not the case. So we as physicians, whenever we give you pain medications for a certain ailment, right, we give it to you for a certain couple of days. So let's say, I always keep on using appendicitis. Okay, so let's say someone came in, they had their appendix taken out, they're ready to go home. We give them some antibiotics and we also give them some pain medication for them to have a relief of their pain as their, body heals. Let's say day 2, let's say we gave them a week's worth of pain medication. Okay, and that particular person goes home, takes the medication, and maybe after 2 or 3 days, they start noticing that their pain has kind of subsided. Okay, but their prescription said use it for 7 days. Are they going to use it for 7 days? No. You don't use pain medication like you use antibiotics. Now if the antibiotics that they told you was to take it for 7 days, then take it for 7 days, because even if you feel better, studies have shown that by you taking it for that 7 day or that 10 day, whatever the doctor has prescribed, that's when the eradication of all that infection is gone. Even if you feel better, there could be some lingering bacteria or infection that's still brewing that you can't feel. So by taking it the full 7 days, or taking it 7 days, or even 14, because sometimes we do that, or even 21, whatever the doctor says you should take it for, take those antibiotics for as long as you can. According to their prescription. But for pain medications, if you're not feeling it after day 3, but it's day 7 that they prescribed it for you, you can stop. It's fine. So that's myth 7. Myth 8. All types of pain response to opioids. And we kind of talk about that. I think we talked about that earlier. Not all respond to it. As we said, neuropathy pain responds to neuropathic medications. Restless leg syndrome responds to vascular medications. So not all pains respond to it. And also, like I said, keep in mind the mind-body effect is real. And so if you have chronic pain and it's all over the place and it's all vague, like you have pain in your stomach, but you also have it in your head, but you also have it in your chest, and you have it in your legs, there may be more than just the pain, and maybe a way of your body saying, I am stressed out, and for whatever reason, my mind is stressed, and maybe you have to deal with whatever is going on mentally before you address if there's any true pain after that. So that's another thing. We're almost done. Myth 9. Morphine is only used for people who are dying. I've heard that before, and for all those who think that, that's false. Morphine is a very common medication that we use in the hospital. I order morphine multiple times throughout the week that I'm on, and for various different reasons. Morphine is not to be used to kill anybody. It's just used as one of the most common pain medications in the hospital, whether you are passing on, or whether you're getting an operation, or whether you're being treated for pneumonia. So if anybody has any thoughts of morphine being only used for hospice patients or those who are passing on, that is false. And our last myth is using someone's painkiller for yourself is totally fine. And that's totally false. Um, I have heard of some of my patients. They come to me and they're being honest, and I like it. I always recommend that you be honest with your doctor, because that's the only way we're able to help you. So as they come into the hospital for whatever ailment, they'll say, "Oh yes, yeah, I just was having some, pain in my chest, and you know, my husband's Norco was there, and I just took one, and just, just to help relieve the pain. And that's what I did to see if it will help relieve it." Now, for them, they think it's very innocent, right? But it may not always be the case, because that medication and that strength was given to that person's husband for a reason. That's what that person's husband's body can tolerate. Now, not everybody can tolerate the same dosage of medications. I think I said this earlier. You can have someone who can tolerate just 2 milligrams and be fine, while someone needs 4 milligrams. Now, if the person who only needs 2 milligrams was to take 4 milligrams of morphine, they may pass out or they may have trouble breathing. So that's why it's important to not use someone else's medications in general, but especially pain medications, because they're not prescribed to you at your particular dosage. Okay. And, and especially with the pain opioid overdose epidemic that's ramping all over the place, that's not something. That's one of the reasons why people are overdosing, because they're using other people's medications, unprescribed, illicit, and they're using it at frequencies that they're not supposed to. And they're mixing it, of course, they're mixing it with other drugs too. And they become addicted, and now they require high tolerance. And it's just a mess that you don't, a road as well that you don't want to go to. Okay. So if you have pain, figure out why you have the pain. Just taking someone's pain medication just to numb the pain is not going to cut it. Remember the analogy I had with the fire. It may or may not knock it. You may or may not get a reaction because you took someone else's pain medication without a doctor's approval. And definitely it's not going to treat the underlying issue of why you have the pain. Okay. So that's it for Q&A with Dr. Mercy. That's it for pain medications. Let me see if I have any questions. So, okay, yeah. So in response to the peptic ulcer disease, yes, that's one of the reasons, producing too much acid. Ultimately, that's the main reason. But again, it could be a bacteria producing too much acid. It could be numerous of other things, which we'll talk about later. But yes, thank you for sharing that. LinkedIn user said, if the vaccine doesn't last 6 months without needing a booster, are people going to have to keep getting boosters forever? Good question. Now, what I think that they're depending on is a herd immunity. They're depending on that the more people take the COVID vaccination, the easier it is to eradicate. Why we still are in this pandemic is because a lot of people are not wanting to be vaccinated. And so as a result, not only is it causing uh, the pandemic to move further, but it is also causing um, variants to occur. And these variants are stronger than the original COVID virus. And so um, I hope we don't have to take boosters forever. That's why I make it a point to talk about COVID vaccinations, because it is found to help. And at this point in this day and age, we have a lot of data in place that shows that it's been helpful in eradicating COVID. It also, wearing a mask and social distancing is helping too as well. So, okay. Oh, this is a good one. I can appreciate starting off on a low dose, but people who have sickle cell disease, for example, or other chronic illnesses know what pain medications they typically use and the dose that works for them. This approach can leave patients suffering unnecessary. Refer them for a pain specialist consult instead. Good question. Not even good question. Good comment, Deborah. You are right. Again, what I was talking about was in acute cases. So if you're coming into the hospital because of a fracture and you haven't had pain medications for a long periods of time, of course, I'm going to start you on a low dose. I'm not going to start you on a high dose. I'm going to start low and just escalate it. I treat it differently than those who come in for sickle cell flare-ups. Like a couple days ago, I treated someone with a sickle cell flare-up. So I'm very knowledgeable about that. And in those cases, I do work with the patient because they do know their body. And that's one thing as physicians we realize. You patients, even though not everyone is a physician that comes to the hospital, you know your body. And so a lot of times if we listen to what you have to say, if we listen to how you feel, a lot of times we're able to pinpoint what exactly is ailing you. Same thing, if you have chronic illness such as sickle cell and you've been in the hospital multiple times, I tend to pay more attention as to what can help you with your pain because you've been there, done that. And so it's more of a conversation to see what you're comfortable in getting as a starting dose and what I'm comfortable in giving you. And it works well. I find that there hasn't been any overdose from that standpoint, and the patient feels that they've been heard. Um, Pain medication specialist or pain specialist, they're a great option for generalists or primary care physicians who have tried to adjust medications for their patients in the clinic and have found it difficult to do so. For whatever reason, the patient is still not getting adequate relief. But let's not get it, let's not come to the assumption that by going up to a pain specialist, all they're going to do is just give you narcotics left and right. They too also offer non-pharmaceutical therapy as well. But yes, if that is something that needs to be done, the outpatient physicians, I'm an inpatient physician, so I work in the clinic, so I don't deal a lot with pain management doctors because a lot of my patients I deal with are acutely having pain. But for those with chronic pain and you've tried to tailor the medications, sure, refer them to a pain management specialist if they need to. So thank you, Deborah, for that. All right. Well, with that, I think we're done for the day. And tune in again next week for another episode of a medical show. It's going to be Medicine for the People with Dr. Susan Ajonwe. And then after that, it'll be with me, Dr. Mercy, Q&A with Dr. Mercy. I do know there's Thanksgiving around, so we may or may not have one in the few days, but just tune in to see if we do. If I don't see you before Thanksgiving, have a happy Thanksgiving, and I wish you guys the rest of the wonderful day and evening. Bye.